Hello, I'm Tony DeMaria, the editor of the Journal of the American College of Cardiology, or JACC, and I'm pleased to be here today on another issue of the Genuine article. And I'm sitting with one of our associate editors at JACC, Greg Feld, who's also the director of the electrophysiology program at UC San Diego. And we're here because we have the February 26th issue of JACC devoted entirely to a focus issue on atrial fibrillation, a very common problem, of course, and one of increasing importance, and one of those areas of cardiology that we thought was sufficiently important and for which there was sufficient new information that we wanted to focus on it. So, Greg, perhaps we could start by talking about the very interesting review article we have on atrial-specific therapy for atrial fibrillation.
Thank you, Tony. For over a decade, we've been using a small cadre of antiarrhythmic drugs that have non-selective effects that may be effective for atrial fibrillation but have an impact on the ventricular electrophysiology, which can produce serious ventricular arrhythmias. Proarrhythmic effects of these antiarrhythmic drugs have been a significant problem, from the type 1 drugs, which can cause ventricular tachycardia, to the type 3 drugs that can cause a different type of ventricular tachycardia called torsade de pointes, which can be lethal. So recent investigation has attempted to focus on the atrium specifically and identify channels that might be only present in the atrium that would produce an antiarrhythmic effect, yet not have an adverse effect on ventricular electrophysiology.
And there are such channels like IKUR, is that one of them?
Yes, indeed. The IKUR is a repolarizing potassium current that appears to be selectively available in the atrium to modulate and not in the ventricle, so you could have an antiarrhythmic effect in the atrium without adversely affecting ventricular electrophysiology.
Well, where do we stand, Greg? Do we have such drugs available? Are they in clinical trials?
At this stage, they're mostly in preclinical trials. There are drugs available that can inhibit the IKUR channel. Another potential target is the IKACH, or acetylcholine channel, which via vagal stimulation could trigger atrial fibrillation. This is a known mechanism. So drugs that block those channels might be effective. And there's also the connexins, which connexin 40 is selective in the atrium, or specifically located in the atrium, so activating it to improve conduction velocity might be of value there. And then there's one other compound, a sodium channel blocker called vernaculant, that's under investigation that may have atrial selective effects also. So in the near future, we may be able to see these compounds brought into the clinical area that might benefit us for treating patients with atrial fib.
Okay, so nothing yet, but clearly an area that lots of attention is being directed to, and in the future we hope to have these atrial selective drugs. Now, a here and now common problem is post-operative atrial fibrillation, and we have an article devoted to that. What's new on the horizon about post-op atrial fib? Any new insights into mechanism?
Well, clearly, prior to the recent studies that we've seen here published today, it wasn't clear what the mechanisms might be for triggering atrial fibrillation post-operatively. But a number of animal models have investigated this in studies in humans, and we think that certainly inflammation may be a factor. There's a pericarditis model that's in animals that is very similar to what we see in post-op AFib in patients. Certainly also increased catecholamine levels that occur after surgery could trigger atrial fibrillation, and shifts in volume and electrolytes may also be a factor. So those are the main things, I think. Inflammation, autonomic influences, and volume changes may be factors that trigger fib after surgery.
Inflammation, does that have some implications regarding epicardial fat pads and how they might be handled at the time of surgery?
Those two issues, in fact, are important. There have been studies looking at anti-inflammatory drugs, even the statins, which could reduce inflammation and may have some impact on postoperative atrial fibrillation. There have also been recent studies that have suggested that, for example, we do ablation of atrial fib, and ablating the ganglia may be important, but a recent surgical study showed, in fact, that preserving the fat pads, not unselectively ablating them, so that you don't get heterogeneity and repolarization may be better than actually ablating the ganglia. So preserving the fat pad at the time of surgery may be important.
May be important. And so the issue of prophylactic value of beta blockers versus amiodarone, some efficacy, but at the cost of some adverse effects. I guess at the moment it's still not clear whether or not they're of value. Is that fair to say?
Yeah, I think the use of beta blockers is well established, and I think that treating patients with beta blockers has been proven to reduce the risk of AFib, and you certainly wouldn't want to withdraw beta blockers. The use of antiarrhythmic drugs such as amiodarone, the use of statins and anti-inflammatory agents also, overall has shown modest benefit, and there are significant side effects associated with them, particularly antiarrhythmic drugs. For example, amiodarone intravenously may produce hypotension and bradycardia. And another drug, sotalol, which is a beta blocker and an antiarrhythmic, does have significant adverse effects as well. So in the balance, the use of those prophylactically may not be warranted, in fact, for preventing AFib.
Good. Well, thanks. Well, these important topics are discussed in the February 26th issue as well as many others, and we'll discuss some more about atrial fibrillation on our next Genuine article.